This module on Ostomy Care is brought to you by Educare, and I'm Jean Howell, and I will be your facilitator. The objectives will be to state the differences between a colostomy, an ileostomy, and a urostomy, to describe characteristics and care of a stoma, and 3, to demonstrate steps in emptying and replacing an ostomy pouch. The digestion and absorption of nutrients, as well as the storage of fecal waste, takes place in the gastrointestinal system, or the GI tract. Digestion starts in the mouth as we chew our food, and then it passes through the esophagus to be digested in the stomach. Partially digested food moves into the small intestine, which is about 20 feet long, and there pancreatic enzymes and bile are secreted to further break down food, and nutrients are absorbed. The food that remains at the end of the small intestine is in liquid form, full of these pancreatic enzymes. The undigested food that then passes into the large intestine, or the colon, solidifies as water and electrolytes, and electrolytes are the substances that maintain balance in the body fluid. There in the colon they are reabsorbed, forming solid fecal material, or stool. The colon is about 5 feet long, and it's divided into 4 parts: the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. The colon has 2 main purposes. One is to absorb water from your stool, and number 2 is to store your stool until you have a bowel movement. When you have a bowel movement, stool and gas go from your colon into your rectum, and then out of your body through your anus. A muscle in your anus, called the anal sphincter, allows you to control when you have a bowel movement. First, I'll talk about a colostomy. A colostomy is a surgically created opening into the colon through the abdomen. Its purpose is to allow the stool to bypass a diseased or damaged part of the colon. Possible reasons for a colostomy would be rectal cancer with removal of the rectum, perhaps a perforation due to diverticulitis or Crohn's disease. A colostomy may be made at almost any point along the length of the colon, but its usual location is the sigmoid colon or descending colon. It may be temporary or permanent, depending on the medical reason for the surgery. When a person has a colostomy, stool is no longer eliminated through the anus. Instead, it is eliminated through the colostomy. To construct a colostomy, the surgeon brings part of the colon up through the abdominal wall. This new opening on the abdomen is called a stoma. Because a colostomy does not have a sphincter muscle, you have no voluntary control over bowel movements. Instead, a person will wear a disposable pouch to collect the stool. The first drawing you see is the placement of the stoma in the transverse colon. This is the section of the colon that kind of travels the width of the belly. And the other picture is one of a stoma. You can see that it's red. I call it kind of beefy red, and it's wet and it's shiny, and this is a very normal look to a stoma. The characteristics of the drainage will be semi-solid or formed stool and gas after the initial recovery from surgery. The drainage will be odorous, and the pouch will have to be emptied just once or twice a day. Another surgically created opening into the body to eliminate waste is an ileostomy. The ileum is the lower 2/3 part of the small intestine. It is the last part of the small intestine before the large ascending part of the large intestine. An ileostomy, like a colostomy, is a surgically created opening in the abdomen through which the end of the ileum is brought up to the surface of the skin, creating a stoma. One reason a person may have an ileostomy would be due to chronic ulcerative colitis. This is ulceration of the mucosa or the lining of the colon. It creates watery stools with mucus and pus, and hemorrhage and perforation or tearing of the colon may occur. Another disease is Crohn's disease. This is a chronic inflammation of the end part of the ileum. Flare-ups with remissions of diarrhea, abdominal pain, anemia, with eventual obstructive intestinal symptoms occurs. Stools are soft and gray or brown with many fecal particles. A person may have polyps or tumors, and these may cause rectal bleeding and may come loose or become infected, even malignant. The discharge of waste from an ileostomy is fairly constant, and it will be liquid or pasty in consistency. It occurs several times a day, generally after a meal. And to note that drainage may change color in response to certain foods. For instance, someone could eat red gelatin or beets, and that may cause the drainage to turn color. A third type of opening into the body to allow waste to drain out or be removed is called a urostomy. The kidneys, ureters, bladder, and urethra make up the urinary tract. The kidneys are two bean-shaped little organs located just below your ribs toward the back, and they produce urine by filtering water and harmful waste from the blood. Urine drains from the kidneys through two small tubes called ureters, and those ureters drain into the bladder. When you are ready to urinate, the urethra releases and urine passes out of the body. A urostomy, or urinary diversion, is a surgically created opening in the abdomen that allows urine to pass directly out of the body. This new opening, with its stoma, diverts urine from a diseased portion of the urinary tract. Because the bladder is removed, part of the small intestine is used to connect the ureters to the abdominal wall. After urostomy surgery, a person no longer has voluntary control over urination. Urine will drain continuously, passing through the stoma and emptying into a pouch. Drainage from a urostomy can be particularly irritating to the skin around the stoma. There may be slight leakage from around the skin barrier or the pouch. There may be irritation from an improper fitting pouch or an accumulation of moisture and buildup of normal fungi on the skin, leading to a yeast infection that we call Candida albicans. I've used the word stoma several times in relation to colostomy, ileostomy, and urostomy. Stoma is the Greek word for mouth, and the stoma is shiny, wet, and red in color. It's similar to the inside lining of the mouth. It will usually have a round or an oval shape, and it varies in size. Each stoma is unique, and one may look slightly different than another. But the stoma should not be painful. It does not have nerve endings, therefore it doesn't transmit pain or any other sensations. It is, however, rich in blood vessels and may bleed slightly if it's irritated or rubbed. This type of minor temporary bleeding is normal. If there is any continuous bleeding or if the discharge, meaning the stool, is bloody, you need to inform the nurse immediately. The stoma will probably be swollen after surgery, and it may take several weeks or months for the stoma to shrink to its permanent size. The skin surrounding the stoma, called the peristomal skin, must be protected from direct contact with discharge. This discharge is potentially irritating since it is very high in digestive enzymes. The area around the stoma should not have rashes or sores. The peristomal skin should look just like the skin elsewhere on the abdomen. One of the most important things a colostomy patient or client can do to keep his skin healthy is to use ostomy products that fit well, minimize leakage, and stay in place. I will talk about your role in caregiving for a client and various types of products available in a few more slides. As I just mentioned, discharge from any type of stoma is potentially irritating. The peristomal skin should be cleansed with each change of pouch. The Clinical Nursing Skills Manual states that warm water and a mild soap that leaves no residue should be used to cleanse around the stoma. Walk nurses, these are wound and ostomy care nurses, often say not to use any soap as many do leave a residue, and that inhibits the pouch from adhering to the skin, which is necessary for a tight seal. Examples of soaps containing moisturizers and oils would be cream soaps, liquid wipes, and baby wipes. I suggest you follow the guidelines your nurse provides for your client requiring ostomy care. To promote the client's self-esteem and body image, be aware of your own body language. Even subtle changes in the way you look at the stoma could indicate disgust or disapproval, and an altered self-esteem could result. Now I'm going to go through the steps necessary to change an ostomy pouch. You can listen to the instructions all day and next week too, but doing it is going to be your best teacher. First, check the client's care plan for any specifics. Determine the supplies that your client will be using. And 3, to gather the equipment. You need an ostomy pouch, and he will use either a 1 or a 2-piece system. You'll need warm water, soft cloths or soft paper towel, a plastic bag for disposing of the used pouch, a tail closer or a night adapter for the pouch, a pair of clean gloves, and a graduate or a bedpan if you're going to measure the output. This is not required in all cases. You will need to have access to a measuring guide so you can measure the stoma and cut the pouch opening to the correct circumference. You'll want some box of Kleenex or tissues, and bring your ostomy scissors with a dark marking pen. And as always, explain what you're going to do and provide the necessary comfort and privacy. Place a bath blanket over the client. You will need a measuring guide to be able to cut the opening of the pouch to fit the stoma, and a box of tissues, and then your ostomy scissors and a dark marking pen. As always, explain what you're going to do and provide the necessary comfort and privacy for your client. Place a bath blanket over him or her and an absorbent pad or towels underneath just to protect the bed in case there's any spillage. Then I like to place a small towel on the abdomen, kind of slide it underneath the pouch to catch any drainage that may occur. To change a pouch, you want to start at an upper corner, and as you remove the old pouch, kind of push against the skin while pulling down on the pouch. Dispose of the old pouch in the plastic bag that you brought, and save the tail closure on the bottom of the pouch. Clean the skin and the stoma gently with warm water and a soft cloth. You want to dry the area well with the soft paper towel or soft tissues. Keep clean tissues available if the stoma functions while the pouch is off. Adhesive removers can also be used to help wash away any excessive adhesive buildup. Observe the skin. Is it free of any redness and skin breakdown? Look at the stoma. Has it changed in size since you last saw it? Is there any ulceration? What is the color? The color should be pink or even beefy red and moist. If it's black, blue, or purple, you need to notify your nurse. This would indicate a non-viable or a non-functioning stoma, and this is an emergency. Measure the stoma at the base with a measuring guide, and then trace the pattern onto the pouch. You want to cut the pouch to the pattern. The opening should be large enough to encircle the stoma without pushing on its edges. No skin or very minimal skin should show between the pouch edge and the stoma. If the client uses a 2-piece pouch, snap the wafer and the pouch together. You want to check for a secure fit by tugging at the bottom of the pouch. Next, remove the paper from the inner wafer and save this pattern for future pouch changes. Apply a ring of skin barrier paste to the opening on the pouch. Then remove the paper from the outer adhesive ring of the pouch. Next step is to center and apply the pouch to the clean, dry skin. Smooth the edges of the adhesive to the skin. If adhesive is wrinkled, it may result in leakage from the pouch. So to promote optimum wear of the pouch, warm the adhesive by placing your gloved hand over the adhesive and gently holding it over the site for a half a minute to a minute. And this will activate the adhesive in the skin barrier. Just so you know, pouches can be applied over an incision. Incisions are sealed within 24 hours of surgery. After you have applied the pouch, close and secure the end of the pouch with the tail closure or the clamp. You want to make sure that the bowed end is next to the body. This provides a better fit to the body and prevents any outpouching of the clamp which may show through clothing. Lay the hook or the clamp on top of the bag and fold the bag 1 inch over the end of the pouch. Squeeze the clamp together to close it. Remove the soiled pouch and your tissues, remove your gloves, wash your hands, assist the client to a comfortable position, and put away your supplies. I have a few further notes before we finish this module. One is that odor should be noticed only when emptying or changing the pouch. Today's pouches are made with an odor barrier film inside of them. And medications, nutritional supplements, certain foods may change the color, the odor, or the consistency of stool. For instance, antibiotics may make stool thinner, and antacids can cause diarrhea and constipation. And speaking of diarrhea and constipation, these conditions can affect an ostomy client just as much after the ostomy as they may have before the ostomy. Clients with colostomy should be able to wear normal clothes. Today's pouches are low profile and fit so close to the body that chances are no one will know if someone is wearing a pouch or not. I've included a few best practices to help you in caring for an ostomy client. The best way to prevent skin irritation is to cut the wafer to the correct size. Less than 1/8 of an inch of skin should show between the wafer and the stoma. Correctly apply the pouch. Make sure that it's aligned correctly and that there are no wrinkles in it. Carefully clean and dry the skin around the stoma. Change the bag 2 times a week. Empty the bag when it's half full. Too much weight will cause it to start to pull away from the skin. Remove excess buildup of adhesive on the skin. And remind the person that they can bathe or shower as before. It's their choice. Water and soap will not flow into the stoma. And check the skin barrier after bathing with a 2-piece pouch to make sure that it's still attached properly to the skin. A client, especially a new ostomy client, will have many concerns and fears regarding the ostomy. What his diet is going to be like, will there be odor, leakage, how can I still be active if that is their choice, and personal intimacies. You are one of the very important people in their life. Your attitude and your presence can help build their self-esteem around the significant change in their life. Even though you have learned some important basics about ostomy care, it will still be important for you to observe and demonstrate care with your nurse. Each client will be a little different, and you must be competent before you undertake care on your own. Practice and time will help. If you have any questions about this content, please ask your supervisor. And now when you are ready, please take the assessment.